Hi, my name is Deborah Baumgarten, and I'm an SAR past president. Today, I'd like to talk to you about the thyroid, and more specifically, using the ACR's Tirads guidelines. I have no relevant financial disclosures. The learning objectives for this talk are to gain knowledge about thyroid nodules and thyroid cancer, including relevant statistics, demographics, and the impact of thyroid cancer on patients, to define and understand the concept of overdiagnosis, to introduce you to the ACR Tirads guidelines for thyroid nodule triage, including some of its limitations, and then to apply the guidelines to some cases. Anyone working around ultrasound in most centers knows that thyroid nodules are extremely common. So here is a question. If nodules are so common, how common is thyroid cancer? The answer to that question depends on the method used to detect cancer. At autopsy, about 2% of the population have thyroid cancer. By clinical diagnosis, about 1/10 of that number, or 0.2%, have cancer. Thyroid cancer only accounts for about 0.3% of cancer deaths and a tiny fraction of all deaths. Most thyroid cancer has been found in the last 30 years or so, meaning there has been a threefold increase in risk since 1990. Now, perhaps this is due to nuclear disasters, such as Chernobyl, but it is also likely due to increased detection of cancer with increased use of ultrasound and other cross-sectional imaging of the neck. And this has in part led to the issue of overdiagnosis of thyroid cancer, which brings us to a second question. What is overdiagnosis? Overdiagnosis is the detection of disease that will never cause symptoms during a patient's lifetime, nor will it be the cause of that person's death. Because the disease itself will never harm the person, harm instead could come from the treatment used to try to cure thyroid cancer. Most treatments have side effects and mortality rates associated with them. There is also the consideration of the costs of these unnecessary treatments, both direct and indirect, as well as the cost to the person who is now labeled a cancer victim. Think of the vulnerability that person now feels. In fact, about half of thyroid cancer in women and 40% in men in the last 20 years is estimated to be clinically irrelevant, meaning the patient would have been better off never having been given the diagnosis of thyroid cancer. One of the reasons there is thought to be overdiagnosis of thyroid cancer is that although the rates of cancer detection have gone up precipitously as charted here from 1975 to 2014, the rate of death from thyroid cancer has held almost constant over the same time frame. Therefore, we are not detecting cancer that is impacting mortality. So that brings us back to our first question. This year, there will be a little over 52,000 cases of thyroid cancer, 3/4 of which will occur in women. Only 2,170 people are estimated to die of thyroid cancer in 2019. Nearly 2/3 of the cases will be in people less than 55 years of age, with the peak age occurring younger in women than men. About 2% of cases will be diagnosed in children. And in fact, it is the most rapidly increasing cancer diagnosis in the United States. So thyroid cancer is relatively common, and we've already discussed the issue of overdiagnosis, which leads us to a third question. How common is bad thyroid cancer, or cancer that will affect a patient's mortality? Fortunately, the answer to that question is not very common. Most cancer is well differentiated and papillary type, which is nearly always indolent. As you can see from this graph, 5-year survival rates from thyroid cancer have improved greatly from the mid-1970s and approach 100%. Most patients who will eventually succumb to their thyroid cancer can be identified at baseline. So what do radiologists do? We triage patients based on what we see at ultrasound and hopefully make recommendations that are grounded in common sense, taking into account individual patient risk factors, as well as patient age and life expectancy. We need to think about the other diseases that they have that are more likely to affect their lifespan. We also rely on published guidelines, which brings us to Tirads, which stands for Thyroid Imaging, Reporting, and Data System, modeled after BIRADS, the system used in breast imaging. The aims of Tirads are to standardize the recommendations we make about incidental thyroid nodules, the lexicon we use to describe nodules, and to report a level of suspicion for cancer for each nodule based on a set of features. Each nodule is described based on this set of features, including composition, echogenicity, shape, margin, and whether or not the nodule contains echogenic foci. Each category is assigned points, which are added together to get an overall score corresponding to a Thyroid's category. The higher the score, the higher the suspicion for malignancy. Recommendations for biopsy are based on the Thyroid's category. So here's another question. What are these Tirads categories? This graphic is borrowed with permission from the ACR Tirads white paper. You can see the points are assigned to each feature, a description of what each feature means and how to add them together to get a Thyroid's category. And we will go over each of these features individually. First is composition. You choose one of the following categories. Nodules that are completely cystic or spongy are given no points, and actually the evaluation can stop at this point. Mixed cystic and solid lesions are given 1 point, while completely solid lesions are given 2 points. 2 points are also given if lesions are completely calcified. Next is echogenicity. Anechoic lesions are given no points, but really we should have stopped at composition since these are cysts. Isoechoic or hyperechoic lesions are given 1 point. Hypoechoic lesions are given 2 points, and very hypoechoic lesions are given 3 points. What may be confusing is that lesions that are isoechoic, hyperechoic, or hypoechoic are compared to the adjacent thyroid parenchyma, while lesions that are very hypoechoic are judged this only in relation to the overlying strap muscles. If the echogenicity cannot be determined, for example, due to lack of adjacent parenchyma or lack of adjacent muscle, 1 point is assigned. There are only 2 shapes, wider than tall or taller than wide, which should be determined on a transverse image. 3 points are given for lesions that are taller than wide. Margin assignment is next, and again you choose 1. Smoothly marginated lesions or ill-defined lesions get no points. Lobulated or irregular lesions get 2 points. And lesions with extension beyond the thyroid get 3 points. No points are assigned if a nodule's margin cannot be determined. And then finally, the type, if any, of echogenic foci. In this case, you choose all that apply. If no artifact or comet tail artifact, no points are given. Macrocalcifications or coarse calcifications, those that generally tend to shadow, get 1 point. Calcifications that are peripheral get 2 points. And those that are punctate echogenic foci, presumably microcalcifications, get 3 points. Again, this is the only category that you choose all that apply and add the values. When we add up the points, we get the Thyroid's categories and the recommendations that go with each category. Tirads 1 gets 0 points and are benign and no biopsy. Tirads 2, which is 2 points, is not suspicious, and again, no biopsy is performed. Tirads 3 is a mildly suspicious category, and one biopsies lesions if they're greater than 2.5 centimeters and follows lesions that are greater than 1.5 centimeters. Tirads 4 confers a moderate cancer risk, with a recommendation for biopsy if the lesion is greater than 1.5 centimeters and follow-up if over 1 centimeter. And the category with the highest risk of cancer, Tirads 5, recommends biopsy for lesions greater than 1 centimeter, and follow-up if a lesion is more than 5 millimeters. As you can tell, the threshold for biopsy decreases as the Thyroid suspicion category increases. There are a couple of shortcuts. As noted earlier, if the lesion is completely cystic or spongy, we stop assigning points, and the lesion needs neither biopsy nor follow-up. Features of at least partially solid lesions that put you in at least a Tirads 4 category are taller than wide, very hypoechoic, extrathyroidal extension, and microcalcifications, because the partially or completely solid piece is 1 or 2 points, and each of these additional features is 3 points. If you have more than one of these, it's a Thyroids 5. Here are examples of Tirads 1 lesions. The first is cystic, the second is cystic with ring-down artifact or colloid. The third is a mixed cystic and spongy lesion, and the final one is completely spongy. Here are some examples of Tirads 2 lesions, which are cystic and solid lesions that have no other suspicious features. Here are examples of Tirads 3 lesions, solid, isoechoic, with no other features. A couple of Tirads 4 lesions, which are solid and hypo or very hypoechoic, and multiple Tirads 5 lesions, which have taller than wide features, microcalcifications, lobular contours, and so forth. Some other considerations include how often to follow lesions when they do not reach the threshold to biopsy. Tirads 5 lesions are followed yearly for 5 years. Tirads 4, a little less, 1, 2, 3, and 5 years. And Tirads 3 even less frequently, 1, 3, and 5 years. But all of these are still followed for a total of 5 years. When to stop following lesions is also discussed, and it is based in part on growth of a lesion. Tirads defines growth as greater than 20% in at least 2 dimensions, or a 50% increase in volume. You need to review old scans to make sure that you are considering growth appropriately. There are, however, no specific recommendations on whether to follow lesions that have already been biopsied. I would refer you to the 2015 ATA guidelines, which have an extensive section on what to do with lesions that were previously biopsied. There are other limitations to Tirads, say as compared to the 2015 ATA system. Tirads is not just a pattern recognition system and then assigning a category. You have to consider each feature and assign a point value and add them up. So it is harder to use once you've gotten used to using a system such as the 2015 ATA guidelines. A Google search revealed numerous online calculators that help, but you do still have to input the value for each category. You also still need to use common sense, especially related to the age of the person, as well as their comorbidities. Don't be afraid to recommend cessation of follow-up or follow-up in lieu of biopsy when it's appropriate. Please don't follow anything up at 3 or 4 months. You don't want to follow up anything too soon. 6 months is considered fairly short follow-up in the world of thyroid imaging. 1 to 2 years is the average. I'd like to say a couple of words about reporting. Each nodule should be described in enough detail that someone reading your report could draw the nodule on a piece of paper depicting the thyroid gland. This includes where the nodule is, the features that give you your Tirads points, the size of the nodule in 3 dimensions, and I usually like to include its prior size, if any, is available to assess growth. It really doesn't take much more time to be systematic in your reports. Tirads recommends categorizing up to 4 nodules with the highest point value. But in my practice, actually, we have our technologists measure up to 3 nodules on each side of the thyroid and, if any, are also in the isthmus. So we could actually be categorizing up to 9. So for example, You could have a superior, medial, anterior, solid, isoechoic, smooth nodule measuring 12 by 15 by 12 millimeters, which would give you a Tirads 3 score, and then its previous measurement of 11 by 15 by 12 millimeters indicates that it's actually stable. Or you could have an inferior, anterior, solid, very hypoechoic, irregular nodule, very close to the anterior capsule, with microcalcifications measuring 21 by 16 by 14 millimeters, and that gives you a Tirads 5 category. The ACR actually has this reporting template, and numbering the nodules consistently from one scan to the next is highly recommended, again, so that you can assess growth. Now let's look at some examples. Here we have a nodule in the thyroid, which is spongiform, and according to Tirads, we assign it 0 points, and then we don't look at any other features. So this is considered a Tirads 1, and we stop. No follow-up, no biopsy. In this case, we have a solid lesion, which is very hypoechoic. It is not taller than wide on a transverse image. It has smooth margins. It has microcalcifications. And when we add up all of those categories, we get a Tirads 5 lesion. And this was a biopsy-proven papillary thyroid carcinoma. Here's a lesion that is solid. It's very hypoechoic in some of its regions. It is wider than tall. It has irregular or lobulated margins, microcalcifications. So again, a Tirads 5 lesion. And it's a papillary thyroid carcinoma. This lesion is solid, very hypoechoic, wider than tall, smooth, with no echogenic foci. This adds up to a Tirads 4 lesion. But given its size, it's biopsyable and turned out to be a follicular variant papillary thyroid carcinoma. This lesion is solid, it's hypoechoic, it's taller than wide, it has extracapsular capsular extension posteriorly. There are multiple echogenic foci or microcalcifications. So again, when we add this up, we get a Tirads 5, and this was a papillary thyroid carcinoma. Another similar lesion. It's solid, hypoechoic, wider than tall, somewhat irregular margins, and microcalcifications. Again, a Tirads 5 lesion. Again, another papillary thyroid cancer. This lesion is solid, it's isoechoic, it's wider than tall, it has a smooth margin, and no echogenic foci. And this adds up to a Tirads 3. And this one turned out to be benign. This lesion is solid, very hypoechoic, wider than tall. It has extracapsular extension posteriorly, microcalcifications, and coarse calcifications. When we add this up, we get a Tirads 5, and again, another papillary thyroid carcinoma. I think you're beginning to see a pattern here. Here's a solid, very hypoechoic lesion with a smooth margin. It's wider than tall but has microcalcifications. Again, a Tirads 5, and again, a papillary thyroid cancer. This lesion is spongiform. So again, we assign no points, we stop, we call it a Tirads 1, no biopsy, no follow-up. This small lesion looks mixed cystic and solid. It's hypoechoic, it's wider than tall, it's lobulated, and are these coarse calcifications? Well, this adds up to a Tirads 4, and turns out to be benign. How about this lesion? We have a solid lesion, which is very hypoechoic. It's not taller than wide. It has a relatively smooth margin where we can judge it, and has broken rim calcification, which you can see here, with extrusion of this solid portion. This adds up to a Tirads 5 and was a papillary thyroid carcinoma. How about this lesion? It's partially cystic. The part that's solid is hypoechoic. It is not taller than wide on a transverse image. It's smoothly marginated, and there are no echogenic foci. This adds up to a Tirads 3 and was benign. This lesion is solid, very hypoechoic. It is not taller than wide. It has a somewhat irregular lobulated border and microcalcifications. This again adds up to a Tirads 5 and is a papillary thyroid carcinoma. This lesion is solid, based on flow, very hypoechoic, wider than tall, lobulated, and has punctate echogenic foci. This adds up to a Tirads 5 and was a medullary thyroid carcinoma. This lesion is mostly solid, is isoechoic. It is not taller than wide. Its margin is very difficult to determine, especially along this border here. There are no echogenic foci. So this adds up to a Tirads 2 and would not be followed or biopsied. This relatively small lesion is solid and very hypoechoic. It is not taller than wide. It has a lobulated margin, but no echogenic foci. It does add up to a Tirads 5, and even though it is a small lesion, came to us already biopsied and was a papillary thyroid cancer. What about this lesion? It's solid when you judge it based on the flow imaging. It's very hypoechoic. It's not taller than wide. The margins are ill-defined. And is this really an echogenic focus? Well, if you consider that it is an echogenic focus, that would make it a Tirads 5. If it's not an echogenic focus, it would make it a Tirads 4. In either case, this is a relatively small lesion, but depending upon whether you judged it to be a Tirads 5 or a Tirads 4 would determine whether you biopsied it immediately or you followed it up until it reached the threshold for biopsy. This did get biopsied and was a papillary thyroid cancer. How about this lesion? It's solid, it's very hypoechoic, it's taller than wide, it's lobulated, there are no echogenic foci, but you also need to notice that the background is very abnormal with multiple small hypoechoic foci. So this does add up to a Tirads 5, but the patient also has Hashimoto's thyroiditis, and this turned out to be a papillary thyroid cancer with an abnormal background. So given this patient's increased risk for thyroid cancer, you would definitely biopsy this, even if it was less than the threshold suggested. In this case, we have a solid isoechoic lesion, which is wider than tall, smoothly marginated, and has coarse calcifications. This adds up to a Tirads 4, but given its size, could be considered for biopsy, and it came back benign. This smaller lesion is solid, very hypoechoic. It's not taller than wide. It's very smooth and has no echogenic foci. This is also a Tirads 4 and turned out to be a benign lesion. In this case, we have a solid lesion. It's mildly hypoechoic as you compare it to the strap muscle. It's not taller than wide, but it does have extrathyroidal extension. There are no echogenic foci. This is still a Tirads 5 and was a biopsy-proven papillary thyroid cancer. This lesion is solid, isoechoic, not taller than wide, has a smooth margin and no echogenic foci. This adds up to a Tirads 3 and was a benign lesion. This small lesion is solid, very hypoechoic, not taller than wide, smoothly marginated with no echogenic foci, and is a Tirads 4. This is below the threshold for biopsy based on the Thyroid categories, but did come to us biopsy-proven as a PTC. And the background in this case also looks somewhat abnormal, so I wouldn't be surprised if the patient also had Hashimoto's thyroiditis. Now, what do you do about this case? This is a case in which the patient presented with lymph nodes in the neck, so something that Tirads doesn't actually consider, but the 2015 ATA guidelines does. So these are lymph nodes that have cystic change. This is all outside of the thyroid. This is labeled lateral to jugular and carotid artery. So these are abnormal lymph nodes. There is no Tirads category for this, but common sense tells us when we see lymph nodes that look like this, we really need to consider metastatic papillary thyroid cancer. This is the same patient's thyroid. If you look closely at it, is there a mass here or is there not a mass here? It looks like there's diffusely infiltrative process going on, including numerous punctate echogenic foci. Again, there really isn't a Tirads category when you don't have a nodule to categorize. However, in this case, the diffuse microcalcifications and the heterogeneity, as well as the lymph nodes that were biopsy-proven metastatic papillary thyroid carcinoma, led to the removal of the thyroid, which showed diffusely infiltrative papillary thyroid cancer. So in conclusion, Tirads is a systematic triage of thyroid nodules. It's a guideline on when to biopsy, follow, or ignore a nodule. And I would say that the use of Tirads is greatly helped by using structured reporting. I hope this has given you a good idea of what Tirads is and how to use it, and that you will be systematic in your approach to thyroid nodules. Thank you so much.